Good evening, everyone. At first, I would like to thank Oncology Club and Radiation Knowledge for organizing such an wonderful event, and also thanks for giving me the opportunity to present my presentation. My presentation topic is plan check, treatment delivery, and verification in breast radiotherapy. Introduction. Radiation therapy is an integral part of multidisciplinary management of breast cancer. Radiation therapy of patients with breast cancer remains a challenging and rapidly changing treatment. It is a characteristic feature of modern radiotherapy that this process is a multidisciplinary process involving complex equipment and procedures for the delivery of treatment. Reviewing of radiotherapy treatment plans and charts by a medical physicist is a key component of safe and high quality care. TG275 provides specific recommendations for physics plan and chart review, which should enhance the safe and quality of care for patients receiving radiation treatment. Literature indications. Clark et al. In 2010 analyzes more than 2,500 incidence reports, and half of the report originated in the treatment preparation process. Nobel et in 2016 reported that most frequent, around 33% near miss incidents originated from treatment planning process. ROILS report in 2016 stated that treatment planning was the most commonly identified process step where events occurs. They studied more than 2,600 incidents. Hazel et al. In 2018 reported that two-thirds common error types originated prior to initial physics plan check and chart review. Physics plan check and chart review. Definition of terms AAPM Task Group 275. Physics plan and chart review is defined as the review of a specific patient's radiotherapy treatment plan and patient chart by a qualified medical physicist or where appropriate their designee to help ensure safe and high quality treatment. There are many aspects to physics plan or chart review as outlined in this report. Examples are technical parameters, accuracy of the calculations, image guidance request, and their consistency with departmental procedure or best practice, plan quality, and proper consideration of technically reported clinical factors. Radiotherapy and image guidance. Around 2 decades ago, where imager was not there, then when we treat our patients, we are targeting our patient and we shoot our patient. Sometimes we are not properly target or the treatment in proper place. So after we getting the imager, then we can see where we have to treat and then we can treat properly. Why is this important? Society level recommendations. ACR technical standards for the performance of radiation oncology physics for external beam therapy. ACR Astro practice parameter for radiation oncology. AAPM task group like 11, 40, and 59. Continuing medical physics consultations, billing code CPT 77336, assessment of treatment parameters, QA of dose delivery, and review of patient documentation reported per week of therapy. According to task group PM40, procedures for checking of technical parameters like daily dose, total dose, fractionation scheme, machine, mode, energy, field parameters, algorithm, etc. Have to check the prescriptions. If necessary, then a special physics consultation is required. Proper documentation should have consistency from prescription to plan to CT simulation sheet to monitoring unit calculation to daily record. Guideline. ACR technical standards, according to ACR technical standard guidelines, Medical physicists must develop a chart review protocol, should review new or modified treatments, assess accuracy of information as well as completeness and clarity of record. Physics chart review must be conducted at least weekly. End of treatment check must be performed within 1 week of treatment. According to TG 275 report considers three aspects of physics plan or chart review. Initial review, that is prior to the start of a patient's treatment, weekly review during the course of treatment, and end of treatment review performed upon completion of the course of treatment. End of treatment check recommendation. Recommended to be completed within 1 week of finish, might be enough time to partly mitigate severe harm. Prior recommendations suggest audit of entire chart at the completion of therapy, including prescribed dose delivery, proper documentation in accordance with departmental policy, treatment summary documenting completion of intended therapy, most failure modes detected likely to be a demonstration, can lead to gap analysis of initial or weekly check. Some aspects for plan or chart review, like technical parameters, where should be checked: the dose, grid, density, override, Gauss tolerance table, isocentral consistency. Then data transfer or plan consistency, documentation or communication, plan quality, and clinical decision making for contouring, image registration, treatment approach, etc. Error detection. Quality control quantification, a tool to measure the value of quality control checks in radiation oncology. A paper published in 2012 where shows lots of parameters. Here, Ford et al. Shows the initial physics plan check where the sensitivity was 62%. Then weekly physics check where the sensitivity was 43%. And then Gopen et al. In 2016 reviewed 3 years of institutional data of 125 incidents, where 38% detected during review. Ezel et al. Shows 25% and 37% of error passed through normal checks. Treatment planning workflow. From starting simulation to end of treatment with treatment delivery, the process should be like simulation, after simulation, simulation checklist, treatment planning, then dose check script, initial physics review, initial physician review, dosimetry plan export, dosimetry checklist, final MDA approval or review, then patient specific QA, final physicist review or approval, then therapist review, and then delivery of the treatment. Patient database nomenclature at our hospital, at United Hospital Limited. It is very important to do a database or to do nomenclature in a systematic way. Like in our hospital, we normally follow in ID1, we normally input the hospital universal ID, and then in ID2, we input our departmental uh, ID. Like if the patient is come for radiotherapy treatment, we start with RT. If the patient come for brachytherapy treatment, we give input like with BT. And then in first name, we normally input the patient's name, and in middle name we input how we deliver the treatment. That means treatment technique like 3D CRT underscore thorax or IMRT pelvis, like this. And in first name, we normally input the diagnosis like C underscore prostate or C underscore breast. If it is left breast, then left, like in this way. And then we assign the treating physician's name, and then we confirm the patient's gender, and then we input the mobile number. If a patient have email ID, then email ID. and then we place the date of birth or the age. We also add the photo of the patients for identification. Nomenclatures in radiation oncology. January 2018, AAPM Task Group 263, they standardized nomenclatures in radiation oncology. Variation in different institutes for confirming the organ in different nomenclature systems. Here we show an example like for left optical nerve structure where we have studied or we have checked 12 different institute, they write down in different way like left optic nerve, optic and underscore L like this way. So AAPM task group 263 they finalized and they structured in a systematic way in 2018. Treatment planning chart review. We normally check or we should check the plan quality, the target coverage, and also have to check the where sparing plan conforms to clinical trial structure used during optimization, physician designed apertures, dose distribution, hotspot, reference point, plan normalization, calculation algorithm, and calculation grid size. Secondary monitoring unit check. The requirement of an independent verification of the monitoring unit or time calculation to deliver the prescribed dose to a patient has been a mainstay of radiation oncology quality assurance. The need for and value of such verification was obvious when calculations were prepared by hand using a lookup table and the verification was achieved by a secondary person independently repeating the calculation. However, in modern clinic using CT, MR, or PET simulation, computerized 3D treatment planning, heterogeneity correction, and complex calculation algorithms such as convolution or superposition and Monte Carlo, the process of and the medical methodology for the monitoring unit verification have come into question. In addition, since the verification is often performed using a simpler geometrical model and calculation algorithm, then the primary calculation exact or almost exact agreement between the two can no longer be expected. Guidelines are needed to help the physicist set clinically reasonable action level for agreement. Breast monitoring unit calculation. I will show an example. Normally sometimes when we do plan and we do normalization with value, suppose here we normalize at 185%. So when we manually calculate the plan after calculation, then it is very difficult to identify the normalization point because there is no normalization point. There has a value. So to solve the problem, we have to create a reference point and we have to document the dose at the reference point. Then we can manually calculate the dose and OIR dose. Simulation review checklist. During simulation, we have to check the CT slices thickness and then region of interest, whether it is fully covered or not. Fiducial marker present and within should be within acceptable limit. Immobilization and positioning device should be documented. CT image quality and breathing artifact. If the CT image quality is not proper, so we have to do it again. Patient positioning and hand position, setup photograph and documentation. Setup photo obviously will be helpful and should be documented. Physicians' comments during the simulation is considered. Contouring overview. User origin defined with fiducial marker. Body contours should done properly. All the wire should delineate plus minus 5 centimeters superior and inferior from PTB. Any spillage in CTB PTB contour in the normal tissue should check. PTB cropped from the screen. Structure nomenclature should maintain. Here I will show an example. Till now, many centers don't have image guidance. So if you don't have an image guidance, if the user origin not defined properly, then it is very difficult to treat with appropriate position. So user origin should define. And then DRR. When someone create a DRR, he should obviously create activate the PTB structure with the DRR. If he activate the PTB structure with the DRR, then technologist can easily know or identify where he has to emphasize to match his structure. So here should carefully do it. And then treatment planning review. In treatment planning review, dose prescription have to check, where doses have to check carefully. Target homogeneity or conformity should check. Dose normalization should clearly mention. Monitoring unit are within the limit. Voice direction should properly check. Adequate skin flash should properly check. DRR image properly done or check. Cause entry correlation should check before treatment. Therapist chart review. When a therapist open the patient file, he should first have checked the DRR image, and then he should check immobilization and positioning device along with set of photographs. Reference point should check whether it is clearly visible or not. New IC center moves with the TPS coordinates. SSD check, field light check on the patients, mainly to check the skin flash. Dose per fraction match with RT plan and simulation prescription. Monitoring unit subtraction applied in the field if the image taken from EPIT system. Cow shift apply after image verification is within tolerance. Weekly chart review. IGRT daily shift data are within the acceptable limit. Have to check. IGRT procedure follow as per departmental protocol. Unexpected severe toxicity should report. Any interruption during the treatment should report. Any changes in the ongoing treatment is properly applied. Compare the recorded dose between the treatment history and OIS. Treatment delivery using EPIT system. If any center don't have the KB images, then he should use the EPIT system. EPIT image can be used to verify the treatment protocols comfortably. And in EPIT, monitoring unit subtraction can also be considered due to a higher monitoring unit is required for EPIT system. Normally, at 8 to 10 monitor is required at AS 500 models, and 3 to 4 monitor unit is required in a S1000 models. Skin flash distance and skin lung distance can be well visualized in the EPIT image and will be helpful to verify the treatment plan. Here, the KBKB match with the orthogonal fields image. So in this image, when you treat the patient, you have to match or you have to verify. Suppose for DIBS patient, you have to be very carefully match the sternum region, rib areas, and also try to match with the vertebral body. Match with the tangential field. In tangential field or with the treatment field, you also can match accordingly uh, your treatment areas or treatment fields are properly matched. If I summarize my presentation, then the physics plan or chart review should be based on risk analysis. Each clinic should develop standardized policy and procedures. Practice should work to incorporate a physics review as early in the workflow. Tools such as checklists and standardization should be used to enhance the performance of the physics plan and chart review. Initial physics plan check, fast, most effective quality control check, where the sensitivity was 62%. Considered automatic tools, 67% of the check item are possible with full automation. Thank you everyone. Thank you for your kind attention. Thank you very much.